chairman, dear audience, thank you the chance to introduce my PhD project today, which is the ultrasonography in diagnostic of the ligament injury. I'm Dr. Koppány Kocsis. I'm working at the Uzsoki Hospital in the orthopedic traumatology department as a specialist. My vision is give a better attendance with faster and more accurate diagnosis for the ligament injured patient. My mission is learn overview the literature and get practice in musculoskeletal ultrasonography. Sorry. To gain this aim, my research will be the comparison of the accuracy of ultrasonography and magnetic resonance imaging, assessing the injured lateral ligament of the ankle and the medial collateral ligament of the knee. My first topic is comparing the diagnostic accuracy of ultrasonography and MRI, assessing in the ATFL and CFL injury. They are the most frequently injured ligament of the ankle. The typical mechanism is of the injury is the inversion trauma. For example, somebody step on a rock or in a hole, and it makes supination stress. We didn't have evidence that a clinical test can evaluate the level of the injury. However, the treatment depends on it. When we would like to know surely how serious is the tear, we use MRI nowadays. However, ultrasonography could be a good alternative because it can be performed immediately during the first patient visit. It's fast, widely available, and relatively inexpensive. Our aim is to compare the diagnostic accuracy of ultrasonography and magnetic resonance imaging. Our clinical question is, ultrasound, is it good enough to quantify the injury? We checked the acute ankle injured adult patient and compared the sensitivity and specificity results of ultrasound and MRI findings. I found several articles in this topic after overviewing the literature. We found 10 eligible articles and examined the specificity and sensitivity of the ultrasound compared to MRI. The sensitivity shows the possibility of finding an injured patient. In 9 articles, we could examine 367 injured patients and found 352 positive cases with ultrasound. It's 97%. It's a very high sensitivity in a diagnostic method compared to gold standard. The specificity shows us the likelihood of finding a healthy patient. In the 9 article, we could examined 152 healthy patients and found 141 negative cases with ultrasound. It's 93%. This is a common form of visualization of a diagnostic tool efficacy. On the vertical pivot is the sensitivity. On the horizontal pivot is 1 minus specificity, as known as false positive rate. As the diagnostic method became better, the summary estimate, marked blue square, goes near to upper left corner. The CFL calcaneofibular ligament injury was found in 7 articles beside ATFL tear. It has a close anatomical location to ETFL, and the mechanism of injury almost the same. Less frequently injured than the ATFL, but we can visualize pretty good with ultrasound. From 178 injured patients, 143 was recognized as a positive case with ultrasonography, which means 86%. The specificity of ultrasound examination is better related to calcaneofibular ligament injury. It's 96%. The summary estimate is in the upper left corner as well, in the two-dimension regression. Summary, we can say the ATFL and according to ATFL and CFL, ultrasonography has a huge sensitivity and specificity to show it's injured or not. The Strangor study were the appropriately selected patient population and circumstantially documented cases. It will be the first meta-analysis that contain only the acute adult cases or limitations. There are just few articles. They were eligible, and there are no RCTs in these topics. In conclusion, I can say that ultrasound has high specificity and sensitivity concerning ATFL and CFL, therefore may be a good alternative of MRI examination in the diagnostic of lateral ankle ligament injury. It could be a primary diagnostic method in the acute cases where MRI is not available. An appropriate classification system and practice is required for the examination. Implication from practice: ultrasound is easy to use, easy to follow up cases, but training is necessary for the examiner. We can select with ultrasound those cases where MRI is necessary. We offer for researchers to developing more sophisticated grading system, and about these grades we can create new guidelines for treatment for better patient healing. The manuscript is submitted as there is a revision at the injury, is a Q1 journal. My second project will be a clinical trial, a cohort study, to comparing the diagnostic accuracy of ultrasound and MRI, assessing in medial collateral injury of the knee. The medial collateral is the most frequent injured ligament of the knee. Neither we have evidence that physical examination can grade correctly the level of the injury. MRI is the gold standard nowadays, but hard to available. And ultrasound could be a good alternative tool. The clinical implication is important. Ultrasound could be grade this injury. I would like to examine the musculoskeletal measured patients with collateral injury without multiligamentar injury, and we will compare the results, the ultrasonography and MRI results. We will exclude the multiligamentar injured and the meniscus tears suffered patients, and I will take the examination with the ultrasound immediately at the first patient visit at the outpatient clinic, and I will send them in the same week they injured to MRI, and we will compare the results. Overviewed, this is my two project to earn the aim to give a better attendance for ligament injured patients, and my quote is about a little bit luck. I'm a great believer in luck, and I find the harder I work, the more I have of it. Thank you for your attention.
So in your first study, any of this, I mean, we could stay here. I mean, you see quite a bit of heterogeneity depending on the paper. So based on this, I mean, I would just ask in a very general way, and then my colleagues that who know this better inside that way. So what do you do better? I mean, because I mean, actually, this is a great sequence that you did a meta-analysis, and then we see that there are actually questions about the specificity and the heterogeneity, but there's a good chance actually this is, and then you actually go for your own studies, and then this is at the same time an implementation actually this stuff. So I think this is the sequence of translational medicine what we really optimally would like to see. So based on that, you know all these studies, you already wrote the paper. So what would you do better compared to this? So what is your vision on this?
Thank you for your question. These 8 studies were very different. Not statistically, clinically were very different. The ultrasound performer, the ultrasound devices were very different. It's about the location, the different countries, the different MRI availables. I think so. We can make a little bit better to examine not just the positive or negative cases. We would like to examine or study the grades of injury, the level of the injury, the the ligament injury has 4 level: the intact, the strain, partially rupture, and complete rupture. And from this 9 study were examined just 1, the grades, and we would like to interpret or vision that we can grade the injury, we can treat more personalized a patient. Nowadays, somebody comes into the outpatient clinic with a torn collateral ligament. We give him a brace, and we say them wear it for 6 weeks. However, if we can grade his injury or her injury, we can decrease the fixation and the illness, the time of the illness. The patient cannot go to work or go back to sport. And I would like to do it better in my study. This one, not the statistically heterogeneity part, the patient selection, the grading. I think so. It's much important.
Nice talk. Congrats. In this case, like a borderline study, orthopedics and radiological study, I am just wondering whether you rely on the report of radiologist, or are you clever enough to evaluate ultrasound and MRI scan?
I think so. I'm clever enough to quantify the ultrasound picture, and I would like to ask help from radiologists to evaluate correctly the MRI, because we would like to use it as a gold standard, and I would like to make a good cooperation with a skilled MRI specialist, and I would like to learn how to use ultrasonography, because as I see in proper countries, ultrasound can use orthopedics and traumatology all days at the outpatient clinic or as a specialist, and not so high quality as a radiologist, but as a point of care examination, we could learn it, because a lot of colleagues can use it, not a general practitioner like a radiologist, but in his specialty can make specialist in ultrasonography. For example, the gynecologist could check the babies, the cardiologist could check the ejection volume, or a lot of things about heart, or urologist could check the renal statement. But here in Hungary, we are using ultrasound very weak, not just in orthopedic, mainly in traumatology. And I think so we can improve the role of fresh injury, the ultrasound, because it's hard to ask a radiologist specialist to help us in the evening or after in the ward.
What in your clinical implication in the daily practice, how many of your patients do you think really get an MRI to rule out any severe injury for the ankle? It's like 10%, 5%, or hopefully not more, because I think there are too many MRIs done anyways. But in your daily practice, what do you think, roughly, how much of your patients do you transfer to the MRI to get any result?
Between 2 or 5%. I think so, not more, because it's a very frequent injury, the torn lateral ankle ligaments, but in every shift we see 2 or 3 patients in a relative small area, and when we see in a whole country or Europe or America, there are huge numbers, and those patients would be necessary to send MRI who has multiligamentar injury or additional bone bruise or other soft tissue injury, for example, vessels or nerve injury.
Agreed. Again, clinically, more important for me, what do you think, how long it takes somebody to learn ultrasound for such specific questions at the knee side or at this ankle?
It depends on the examiner and the teacher as well, I think so. And
maybe 100 cases, 50 cases, what do you think? What do you think is a good number? Obviously more than 10.
100 cases. I think so. It's when the teacher is well prepared, and it's a specialist in musculoskeletal ultrasonography. It's enough to 50 to 100 cases.
I'd like to ask if you have any information about the used ultrasound heads and the field of MRI they used in these studies, because we can see there is a big interval between the studies published.
Yeah, thank you for the question. The device is very important. Yeah, it's a technical sport. Yeah. MRI, we heard about from Luca how important could be the technique. In ultrasound is the same. I think so that the technique is improved very, very fast in the last 20, but in the last 10 years. And the ultrasound heads are very good already. Before 20 years, we cannot imagine that we could see the fine structure of the ligaments. But nowadays, with the high resonancy, high frequency ultrasound heads, we can see the fine structure, not just the ligaments, that the nerves as well. And in these studies were used 7.5 megahertz and 8 till 12 megahertz heads for checking the ligaments. But there are higher frequency ultrasound heads as well, and some studies going about 15 and 18 megahertz ultrasound devices, which can show the fine structure. But I think so that all days we didn't need so much frequency, so high frequency heads. For grading is enough the 8 to 12 megahertz heads. Linear head is very important because the curved heads using for check the babies.
Okay, you use the specificity and sensitivity. Why this? Why not positive or negative predictive values? What is the difference between sensitivity and specificity and positive and negative predictive values?
Yeah, thank you for the question. Sensitivity and specificity is a well-known modality, and all these 2x2 tables, the diagnostic, when we check the diagnostic efficacy, we used sensitivity and specificity. The sensitivity shows that how many positive cases we check in injured patient, and the specificity, how many healthy we find in the how many negative cases we find in the health population. And the positive and negative predictive value is a little bit different, and it's easier to ask for practitioners to check the sensitivity and specificity. We told a lot about the orthopedic traumatologist. We are simple patients, simple guys. It's easier to check, to talk about just specificity and sensitivity. It's easier for us.